Hello, welcome to Cardio Flash College, a place to learn cardiology with flash animations. Today we continue with our weekly section Flash Code, a place to explore the world of acute coronary syndromes and primary angioplasties. Let's begin. This week we have a male of 76 years of age with a personal background of arterial hypertension, dyslipidemia, and former smoker, without any other background of interest. He is moved to our unit with a diagnosis of an ST segment elevation acute coronary syndrome of 6 hours of evolution. At his arrival, the patient mentioned chest pain, dyspnea, and he presented signs of acute heart failure. This is the electrocardiogram of our patient. As you can see, it is evident the existence of changes on the ventricular repolarization. These alterations express as elevations or descents of the ST segment in some leads, and they suggest an acute myocardial lesion. Could you identify these disturbances? That's it. In this electrocardiogram, we have QS complexes and an elevation of the ST segment on the anterior and lateral leads, and also an image mirror descent of the ST segment on inferior leads. This means that we have an acute myocardial lesion of subepicardial or transmural characteristics, sufficiently evolved to create a broad myocardial necrosis in the anterolateral region of the left ventricle, which translates into an ST segment elevation myocardial infarction in this case. But what clinical relevance does this have? Very simple. ST segment elevation myocardial infarction is the regular clinical manifestation of a complete blockage of a coronary artery and constitutes a cardiological emergency where every second counts. In this way, our main objective is to open the artery as soon as possible, whether it is using fibrinolysis or primary angioplasty. In this case, cardiac catheterization is made. As you can see, right coronary artery is open and it does not present any significant lesions. On the other hand, and as expected, the anterior descending artery is closed at its middle segment between the first septal branch and the first diagonal artery. Now we know where the obstruction is and we only need to treat it. First thing to do is to pass an angioplasty guide wire through the closure. Sometimes, as in this case, passing the guide wire partially opens the artery and allows us to see part of the distal bed. In this case, it is evident that the anterior descending artery is very ill and full of thrombus, presenting ectatic segments that alternate with segments with stenosis. For this reason, and with the intention of avoiding the mobilization of the thrombotic content, a direct implantation of a drug-eluting stent was made. Unfortunately, almost immediately, a no reflow phenomenon occurred. The no reflow phenomenon is one of the most severe complications of the cardiac interventionism. It involves a decrease of coronary flow due to the obstruction of microcirculation, many times as a consequence of the distal embolization of the coronary thrombus. As you can imagine, these little blocked vessels are not visible in the coronary angiography, and the consequences of this phenomenon are what we can only see. These visible consequences are retention of contrast material in epicardial blood vessels and clinical instability. Moreover, the problem of the no reflow phenomenon is that we do not dispose of many therapeutical alternatives, because treatment basically consists in the administration of intracoronary vasodilators such as adenosine and nitroglycerin. The intention is to achieve a maximum state of vasodilation at the level of the microcirculation, and so using a distal coronary infuser microcatheter might, many times, be helpful. Other frequent strategy consists in the administration of strong antithrombotic drugs such as the inhibitors of the 2B3A glycoprotein. Meanwhile, if coronary perfusion does not improve and ischemia prolongs, it is usual that the patient enters heart failure or cardiogenic shock. For this motive, applying circulatory support measures might be necessary, for example the intra-aortic balloon pump, or, as in this case, a percutaneous ventricular assistance. And so, after securing clinical stability of the patient, the best we can do regarding coronary interventionism is to adopt an expectant behavior, because continuing with the procedure could definitely compromise the few blood flow that we help return. However, as you can see, angiographic result is suboptimal, and so electrocardiographic alterations do not improve or even progress, because a complete right bundle branch block that did not exist is now evident. In any case, we must know that independently of the patient having made it out or not of the cath lab, the no reflow phenomenon, the cardiogenic shock, and the need of ventricular assistance form a clinical picture of dark prognosis. With this final message, we say goodbye. It has been all for today in Cardio Flash College. We hope you liked the video. If so, subscribe to the channel and leave a like. We'll see you in the next class. And remember, don't come late. Bye.